Hi, welcome to our case series discussion, case number 4. I am Dr. Keshwar, Director Cardiology, Fortis Hospital, Cunningham Road, Bangalore. I welcome you all for this interesting case discussion for physicians and budding cardiologists. Today we have a 42-year-old male, mild hypertensive, no diabetes. He was otherwise healthy. He had gone to a visit to Kashmir and was coming back by flight. In the flight, while he was sitting, he felt uncomfortable and started profusely sweating and had a blackout. His wife was next to him, and his wife said that he was unconscious for around half a minute. And immediately emergency was sounded, and the doctor on flight, who was a co-passenger, was called, and he examined the patient, and he told that his pulse and BP were very weak, and he had involuntarily passed urine, and he recovered consciousness in 20 minutes. He had no past history of similar episodes. He had no history of convulsions. He was not on any anti-epileptics. He had taken his breakfast 2 to 3 hours before, so ruling out basically a hypoglycemic episode. And this was in the flight. And second episode, he had a similar episode after a few months. While coming back in a lift down in a hotel, he felt a similar feeling and had again a blackout for around 30 seconds. This time his wife was also with him, and she said he was very pale at that point. And the only thing the patient was saying was, the lift was very crowded, there was no AC, I didn't feel comfortable. And the lift was going, I couldn't call anybody, and he had a blackout. This time he didn't have any micturition and involuntary micturition. So here we have a case of syncope, that is a case of sudden onset of loss of consciousness. When he came to me, there was no pallor, cardiovascular system, RS and all was normal. BP was normal, there was no change in the BP when he was lying and standing. Both was same, and his ECG showed incomplete RBV. Echo was normal valves, no regional wall motion, no LVH, no hypertrophic cardiomyopathy. Holter was normal, occasional VPC, no brady and tachyarrhythmia was noted. And neurologist patient had already seen a neurologist before coming to me. He suspected question mark or possible seizures. EEG was normal, MRI brain was normal, and carotid Doppler was normal. So this was the working diagnosis. So what is the diagnosis? What is the treatment? What is the prognosis? He was very anxious, whether it is a seizure, whether he will have a recurrent episode, should he change his job, should he stop driving, what will happen if he drives, what will happen when he has an episode when he is driving or climbing staircase, can he do swimming, what will happen if he develops a similar episode during swimming. These are all the issues with which he presented to me. So let us discuss what is syncope. Syncope is a syndrome where there is sudden relative transient loss of consciousness, temporary, and it is important thing is self-terminating, and usually you will have a rapid recovery. And the basic phenomena is inadequate cerebral perfusion, and this will cause the fall in the BP and fall in the postural tone and loss of consciousness. The most important thing is self-limited and is a loss of postural tone and relatively rapid onset. Variable warning symptoms may be absent in older patient because with amnesia of the event, and you will have a spontaneous, complete, usually prompt recovery without a medical or a surgical intervention. So the underlying mechanism is transient global cerebral hypoperfusion, whether it is a decreased cerebral perfusion, but it's transient, and patient will spontaneous, complete and a prompt recovery without a medical or surgical intervention. That is the most important thing. There will be no deficit, unlike a stroke or a TIA, that will be the important symptoms. What are the causes of syncope? They can be broadly classified into neurally mediated syncope, in which we get a vasovagal syncope, carotid sinus syncope, situational syncope, what you call a cough syncope, micturition syncope. And the next important cause is orthostatic hypotension, that is drug-induced hypotension or autonomic system failure, either primary or secondary. This constitutes 15%. Neurally mediated syncope, vasovagal syncope constitutes around 60%. Cardiac arrhythmias contribute around 10%. Bradycardia or a tachycardia, VT, VF or a long QT, Brugada and all. Structural heart disease, aortic stenosis, hypertrophic cardiomyopathy, pulmonary hypertension, pulmonary embolism, dissection contribute around 5%. After all this, there is a 10% of the causes may not be known even after a multiple battery of investigation. Still, you will not be able to come to a conclusion with unexplained causes. What is the commonest age group? Commonest age group is around 15 to 25 years. We have a peak around most of these syncopes happen in that age. Again, in the mid age, it comes down, and after 60 years, 17 years, again there is a second peak of syncope. Now, if you go by the age, less than 40 years, commonest cause is a neurally mediated syncope, or what you call a vasovagal syncope is the most commonest. Cardiac, structural heart disease and all contribute to less than 10%. In 40 to 60%, 40 to 60 years of age, commonest will be still a neurally mediated, but percentage of due to arrhythmias, orthostatic hypotension, cardiac structural disease goes up. And it's more than 60 years, if you see, the arrhythmias is contribute around 15 to 20%, orthostatic hypotension 15 to 20%, structural heart disease around 15%, neurally mediated syncope will be approximately around 50%. So as the age goes up, organic heart diseases will be the predominant causes. So how do you evaluate this patient? You take history, examination, please check the BP in lying and standing, ECG, and you have to do a risk assessment whether this patient needs admission or can you do as outpatient, and ECG, Holter monitoring and all will be needed. Hospital based will be further invasive based studies we will decide. Now in the history, always ask for the history of medication history, especially if the patient has taken diuretics or a BP medicines, and food history, whether the patient has taken the food on that day, diabetes, and strong history of family history of sudden cardiac death, history of cardiac disease you take, and past medical history like history of ischemic heart disease, MI, arrhythmias, metabolic disease, neurological disease you take. Always call a eyewitness account, as in this case we had his wife who was giving the witness about what had happened. Luckily we had a doctor on the flight who also told that his pulse and BP were weak, and warning symptoms you have to ask the patient, and history of possible similar episodes in the past you are going to ask. On examination, if you are able to see the patient immediately after a syncope, check the pulse, BP, irregularity, murmur, LVH, BP lying and standing, cardiovascular examination whether the murmurs are there, carotid sinus massage, tilt table studies and all we will discuss, and neurological examination to see any deficits are there, any post-ictal confusional status are there, you are going to see. And what are the symptoms, features suggesting is neurally mediated syncope or vasovagal syncope. Usually there is no history of heart disease and multiple episodes may be there, and the most important thing is precipitation is precipitated by pain, heart environment, head rotation, prolonged standing, volume depletion and strenuous exercise. Say for example in our patient, I gave you a clue that he was returning from Kashmir, it was very cold, he was wearing a thermals and all in the flight, and suddenly after the flight the temperature was different and he started sweating. So the temperature, he was wearing a very cold environment dress in a hot environment, so he was not able to sweat and there was a stuffy atmosphere inside the plane, he had a vasovagal syncope. Orthostatic hypertension, you take the history of any gastroenteritis, loss of blood, loss of recent surgery where the volume depletion, diuretics, vasodilatation, especially alpha blockers like prazosin, and the history of neuropathy, diabetes because they have autonomic neuropathy, alcohol abuse also have autonomic neuropathy. Family history of cardiovascular disease, sudden death is very important. and whether it happened during exercise, supine, and these will become very important. So past history of MI, arrhythmia, hypertrophic cardiomyopathy, these things will become very important. So which patients are low risk, which patients are high risk? Suppose you have a major risk factors like abnormal ECG, history of heart disease, BP less than 100 and heart failure, he will become a high risk. And a minor risk like a elderly person, anemia, dyspnea, and hypertension, CVA, family history of sudden death, these will be the minor risk factors. So if you have a more major risk factor and more minor risk factor, these patients will need a admission and evaluation. So which patient strongly favor the in-hospital evaluation is if you have a suspected history of heart disease. Say for somebody has history of MI 1 year back and he has a blackout, somebody has history of pacemaker and has a syncope, ECG abnormalities suggesting frequent VPCs and ill-sustained VT, these things will necessitate this patient, even if he has one episode of syncope, needs admission. And syncope during exercise suggests usually arrhythmia. Syncope while supine, that means that the heart is quiet and still has a blackout, that's also a bad sign. Severe injury or accident, if somebody has fallen and injured with a injury to the head and all, needs admission. The family history of sudden cardiac death, usually think of hypertrophic cardiomyopathy, long QT syndrome, Brugada syndrome. These patients will need admission and evaluation. What is postural hypotension? How do you diagnose postural hypotension? If somebody is lying down, you check the BP and make him stand up for 3 to 5 minutes. And if the BP, systolic BP comes down by 20 millimeter, diastolic by 10 millimeter, we call it a orthostatic hypotension. In a hypertensive patient, you have to diagnose it by if the fall is more than 30 millimeters of mercury. Sometimes symptoms can be delayed up to 5 to 15 minutes. There is another simple test you can do with a monitor attached, is a carotid sinus massage. Make the patient lie down, massage for 10 seconds at one carotid, cannot do bilateral at a time, is absolutely contraindicated. Single carotid massage for 10 seconds with the thumb of the hand over the carotid and do a rounded massage. And if you can do it in a supine or upright posture on a tilt table, but it has to be under a monitoring. And if there is a carotid on massage, if there is a pause for more than 6 seconds or BP falls more than 50 millimeter, and that's what you call it a positive carotid sinus massage test. And relative contraindication is there is a BRUI, and if there is a significant carotid artery disease, if there is a history of CVA in the last 3 months, acute MI in the last 3 months, it is contraindicated. And complication can have a TIA-like symptom and is usually less than 0.2%. So additional test, what tests you would like to do? Both the previous test, carotid sinus massage, can be done in a CCU or a monitoring this thing. Orthostatic hypotension, you can evaluate bedside or in the clinic chamber. Other important tests are ambulatory ECG or a Holter test, what we call this one, loop recorder. Here you monitor for 24 hours to 72 hours, sometime up to 1 week. Then there is a tilt table study which we will discuss, electrophysiological study and a EP study. There are other less sensitive specific tests called signal average DCG, heart rate variability, heart rate turbulence, T-wave alternance, QT dispersion. These are all tests available with a lower sensitivity, specificity, and not usually routinely done. So our ECG will give you a recording for only 10 seconds. Holter can be 1 to 3 days. Event loop recorder can be kept for 7 days to 30 days. And then you have a mobile cardiac outpatient telemetry, can be kept for 3 days to 30 days, which is not easily available in India. Loop recorder is easily available, patches 7 days to 30 days it can be done. Implantable loop recorder can be kept for up to 3 years. It's a small device which can be implanted in the third and fourth intercostal space. It can record one lead for up to 3 years. This is recommended for people who have very infrequent episodes of syncope. Say somebody has a syncope once in 3 months, 4 months. Your ECG, Holter, loop recorders all will come normal. and especially these are indicated when there is a syncope is really life-threatening. Suppose he had we had recommended a patient for an implantable loop recorder who had a syncope, but the doctor found that there was no pulse BP. He had to undergo cardiac CPR, and after that ECG, angiogram, everything was normal, EPCD was normal. This person underwent a loop recorder because he had a life-threatening episode of a syncope. So that's where he was, implantable loop recorders are recommended if you have a very serious episodes of syncope causing injury, but all the other tests are becoming negative. So implantable cardiac loop recorder, you see in this there is a small 1-inch device which is kept in the third or fourth intercostal space, and multiple manufacturers are there. This will record events in one lead, and the most important thing is it will record whenever it's programmed to either bradycardia less than 50 or heart rate more than 110, it will automatically record. So if the person has a syncope, there is no need to activate it, it will immediately be recorded on the loop recorder. This is how the loop recorder looks like. So in this patient, what we found was a refractory syncope when they had a seizures. In the first patient, we found that patient has a prolonged episode of pause which was not detected by event recorder, Holter, and a prolonged 7-day Holter also didn't record. This loop recorder recorded one episode of this bradycardia happening after 6 months. So this patient underwent a pacemaker, and the events were further completely disappeared. The second episode is a syncope accompanied by this one. So here you see that he had a recurrent episodes of VT, and this person had a refractory VT which needed a defibrillator as this one. Another simple test which many physicians can do and not being done is called a tilt table study. What is a tilt table study? Here you see in this patient is made to lie down on a table which has got a pedestal, so that this one, and there is a band which is put over the patient so it doesn't fall, and so we use some of the drugs. What is the important thing is if you go through literature, protocol is not fixed. Some say 60 degrees, some say 70 degrees, 60 degrees for 30 minutes, 70 degrees for 20 minutes. So there are different protocols. We can follow one what is available, because none of the protocols are still standardized, and it will unmask vasovagal syncope susceptibility, reproduce symptom. Patient will give you a warning symptom that he is going to feel the symptoms, and the patient more confident of diagnosis because he will experience the similar episodes. Basic preparation: 4 hours fasting, ECG monitoring continuous with a printout like a ECG. So what we do is we do it in a TMT room where the patient is connected to ECG and the continuous BP monitoring. We'll if there is a bradycardia or some episode, we do record it immediately. And what we also do is in the supine position we do a carotid sinus massage as a protocol for a head-up tilt test or a tilt table study, which can be done by anybody. So suppose if you don't have a tilt table predominantly, we used to do this in a radiology room, but the most important thing is the room has to be quiet, patient has to be 4 hours fasting, there should not be noise, there should not be loud disturbance in the room, and so one of the protocol is supine rest for 5 to 15 minutes, tilt 60 to 70 degrees for 20 minutes. If he has a syncope or bradycardia or hypotension, the test is positive. If negative, then after 30 minutes you give a drug, especially nitroglycerin sublingual or isoprednolone, to increase the heart rate to 125, and extend the tilt after a drug for another 10 to 15 minutes. If even after the drug is negative, we say the tilt table test is negative. If it is a vasovagal syncope, patient will have positive. Here you see that the BP after some time, after 20 minutes, 30 minutes, 35 minutes, suddenly there is a BP fall and the patient became symptomatic. Here again the same patient had a bradycardia. So this is the heart rate, this is the blood pressure. You see that hypotension and bradycardia was triggered by the tilt this one. So what exactly happens is a exaggerated Basalt-Jarris reflex. So how do you describe a vasovagal syncope or a positive tilt table is there is a miscommunication between the heart and the brain. So whenever there is a decreased LV cavity, there is a decreased venous return, say prolonged standing, there is a decreased venous return. This decreases the BP and increases sympathetic activity, and usually this will increase the BP and inotropy contractility, and the BP will go up. So whenever there is a decreased venous return, there is a small ventricle, and the C fibers, mechanoreceptors in the left ventricle, will send the signals to brain as a part of Basalt-Jarris reflex, and the brain thinks that the LV cavity is small, is hypercontractile, so it thinks that there is a mechanoreceptors are hyperactive, and they thinks that the BP is very high, and it gives a command which increases the vagal efferent activity, so that will reduce the heart rate. So increased vagal activity will reduce the heart rate, and sympathetic withdrawal will cause vasodilatation. So the patient can have a bradycardia, patient can have hypotension, and it will cause syncope. So this is an exaggerated Basalt-Jarris reflex. This trigger can be prolonged standing, dehydration, or you can say like in our patient, which was also diagnosed as vasovagal because he had a positive tilt table study. He was in a stuffy atmosphere in a lift. He had worn a cold climate dress in a very hot environment. He was not able to sweat, and this caused the decreased venous return, small ventricle, and the exaggerated this one. So the most important thing is the stimulus is hypercontractile LV, which stimulates the receptor. So what is the most important thing? Hypercontractile LV has to be made to contract less. So negative inotropic drug is the treatment of choice because that will prevent this circuit being complete. So what happens is the best drug for to prevent Basalt-Jarris reflex or a vasovagal syncope is a beta blockers, or sometimes we use a drug called midodrine, which is not available in India, but we routinely use a beta blocker which will prevent the episode from initiating from the left ventricle. So this is how it is being done. Continuous monitoring, 70 degrees ECG monitoring is to be done. So here you see that ECG was normal at pre-test, 1 minute it is slight tachycardia. After 12.5 minutes there is a bradycardia and the BP has fallen, and the BP has come down to 55/30, and immediately you are switched back, and it's a positive response to neurally mediated syncope. So neurally mediated syncope can be of 3 types. Type 3 is called vasodepressor, where only BP falls but the heart rate doesn't fall less than 10%. Type 2 is called a cardioinhibitory. Type 3 is vasodepressor, type 2 is cardioinhibitory, type 1 is mixed. Type 2, the cardioinhibitory 2A and 2B. 2A is cardioinhibitory without asystole, BP falls and the heart rate gets below 40 but no asystole. But 2B is cardioinhibitory with asystole. Without asystole is 2A, with asystole is 2B. Type 1 is mixed, where cardioinhibitory and vasodepressor, both types are there. So sometimes the patient has what you call a malignant vasovagal syncope, especially of cardioinhibitory type. Pacemakers may be of this one, but we will discuss about this in the subsequent few slides. So there are different protocols, 45 minutes, 60 degrees, and but you have to realize that the sensitivity is 75%, specificity is 95%. There is another protocol which they claim a specificity of 94%, but different protocols are there. We can follow any one of this. Now, does the patient need EP study for a syncope evaluation, especially if the patient has structural heart disease? Say if somebody has a syncope with EF of 30%, somebody has HCM, somebody has a Brugada syndrome, somebody has a bradycardia and the Holter, somebody has frequent VPC, ill-sustained VT and the Holter with a normal heart function, normal ejection fraction, then we recommend EP study. And there we check the sinus node, we check the His bundle, we check the VT induction, all these things we check. Most important thing is sensitivity, specificity of EP study in syncope. with stable heart disease, with structural heart disease is only around 25 to 71%, without structural heart disease 6 to 7%, less effective. So we don't routinely recommend until unless we have a clue on the echo, Holter, or a event recorder. It shows something, or the patient has a life-threatening syncope. When all the tests are negative, then only we recommend. But knowing that false positive findings are more frequent in structurally normal structural heart disease is not there, then the chance of finding a significant positive EP study is low. Do you need to refer the patient to neurologist? EEG, CT, MR is of little value. Only if the patient has a past history of seizures or history of head injury, then it may be needed. EEG only if seizure is a concern, but EEG may not be diagnostic. Neurological consultation before this test is better. So coming to vasovagal syncope, vasovagal syncope is most common in young people, otherwise healthy people. Typical prodrome triggers. Typical example is unpleasant smell, unpleasant taste, unpleasant environment, emotions. You would have heard of somebody has a bad news, he fell unconscious. Somebody had a good news, he fell unconscious. Somebody was standing in a bus stop for a longer time, he fell down. Somebody had dissection, first year MBBS, standing lost, dissection, formalin smell, fell down. All these are vasovagal smell, syncope. 70% of the populations have predisposition for this, usually common in persons with high stress, no known genetic disease basis, and no evidence of autonomic involvement, hormonal disorders, low risk of trauma, and frequent spontaneous disappearance in later life. Most of the time these episodes will disappear as the person grows on this thing. So this is also described as neurally mediated syncope. It can be cardio inhibitor or vasodepressor or a combined, which we have already discussed. And what is the treatment strategy? Educate the person that this is a miscommunication between the heart and brain, and reassurance. Avoid the episodes or whatever precipitated, you avoid. Most of these patients will have BP of 90, 100 systolic. So increase the salt intake, increase the volume intake. Using elastic stockings also improves the venous return, which can increase the BP by around 4 to 5 millimeters. And standing for long hours is better avoided. If somebody is asked to stand for long time, muscle tensing, leg crossing, these things will also help in improving the BP and preventing the episodes. Carotid sinus syncope is because of the stimulation of the carotid sinus, reflex increase in the vagal activity, and diminution of this sympathetic activity causes the carotid sinus this thing. So in that scenario, please avoid the turning, sudden turning, movements in those things should be avoided. We do see a patient, somebody having a big lymph nodes in a malignancy, pressing on the carotid sinus. Whenever he turns the head, he has a blackout. So the sudden turning of the movement should be avoided. Orthostatic hypotension, basic thing is to avoid drugs which cause orthostatic hypotension, like diuretic, alpha blockers, centrally acting drugs like vasodilator, antidepressants, and these things should be avoided. For a diabetic persons should be trained how to avoid vasovagal syncope or hypotension, sudden change in the posture. When he does, he has to go slow, from lying to sit for 2 minutes, stand for half a minute, and then move your legs before getting up from the bed. Will avoid these symptoms. Cardiac syncope can be MI, hypertrophic cardiomyopathy, aortic dissection, pulmonary embolism, valvular abnormality, myxomas, and so these patients, ECG will be abnormal. So ECG, white QRS, sinus bradycardia, pre-excited ECG suggesting WPW, short QT, long QT, Brugada pattern, negative T wave, arrhythmogenic right ventricular dysplasia, previous Q waves, old history of MI, they will all suggest a cardiac syncope. Coming back to what happened to our patient, he had a positive tilt table study of a vasodipressor type. Whenever we did the tilt table, his BP came down to 70 within 10 minutes without using the drug, and immediately we made him lie down flat. His Holter was normal, no further episodes over 6 months to 9 months, and he was put on beta blocker, and he had no further episodes. As we told, vasovagal syncope has got a benign prognosis. Most of the time it will not recur, and both the times our patient had a syncope because he was in a stuffy environment and his dress was not suitable. Second was he was a congested place in a lift. He had a similar episode. So both after that he had no further episodes. Prognosis is good. He will not need any further intervention. So friends, in this case we discussed what is syncope, what is the definition of syncope, and what are the commonest causes for syncope, at what age, what type of syncope is quite common. And the most commonest cause for syncope is a vasovagal syncope, which is a high risk patient, which is a low risk patient, we discussed. And the most important thing is all physicians should be aware of a test, most important Holter, and other important thing is about a tilt table test, which is a simple, easy to do. Any good physician with a good, if you don't have a typical tilt table, you can do in a radiology department. You need a calm, quiet atmosphere. Patient should be fasting for 4 hours, should be a foot pad paddle so that he doesn't fall, and a binder has to be there on the abdomen so that in case he has syncope he doesn't fall and injure. And you need a monitor to take a ECG printout every 10 minutes, check the BP regularly. So you can do it in a treadmill test room, you can tilt if you have a similar type of test. And the prognosis is very good. You can convince the patient, and easy to do, not very difficult, low risk, and you can do all the non-invasive evaluation you can do before referring the patient to a cardiologist. That's very important. And most important thing is to identify a patient who will need immediate attention. That is also very important, so that you can refer the patient. Thank you very much.